Hello, can you hear me?
Yes, afternoon, sir. Yes, we can hear you, sir. Good afternoon.
Good afternoon, Dr. Baturi.
Right.
Yes, sir.
It's nice to see
How
you.
is
Good. Yes.
nice to see you, sir. How is Germany?
Oh, Germany is there. I can see my face is dark, right?
Well, it's bright now.
Okay, let me bring this light closer. Am I bright enough?
Yes, it is.
Okay, good. Thank you. So, we still have some few minutes, right? Hello?
Yes, sir, just a few minutes before we kickstart.
Okay. I've not seen Chief Akimiemi.
Is logged in, sir.
As Kingsley Okoli.
Okay.
Good day, Dr. Sadiq.
Hey, Chief, longest time.
Good to see you.
Yeah, thank you, sir. How is the Glaucoma Society and everything? I see all your.
Well, we thank God. We're okay.
Oh, that's good.
Happy World Glaucoma Week.
Thank you, thank you. I didn't know you were in Asaba. I thought you were in the West.
I started the journey from the West, so I had to move to the south after a while.
Oh, that's great. That's great.
Well done.
Thank you, sir.
You seem not to be around.
Yes, yes. Just a month back, but I'll soon be back.
Okay, that's cool. Well done.
Thank you, sir.
Right, it's past 2 already, so how do we go?
Yeah, I think we should just start. YYF.
Yes, sir. We're good to go.
I think we can just start. It's already.
So I need to share my screen, so you make me the co-host, so that I can share the screen.
Yes, I think they control that part.
You're already a co-host, sir.
You're close already, sir.
All right.
Can I start?
Yes, sir.
Oh, okay. You're all welcome to this week. It is very important week for us in Glaucoma Society of Nigeria, and indeed all over the world, and for all other ophthalmologists. Glaucoma is a big problem. It's the #1 cause of irreversible blindness, not only in Nigeria, but in all over the world. And a lot has been said about glaucoma awareness. And this time around, the YOF decided to look at the services we provided. And they have really made a big catch by getting Chiba Kinyemi to deliver the lecture. He's actually an experienced glaucoma specialist. He had his MBBS at the prestigious University of Ibadan and his fellowship of both colleges of West Africa and national. And he also had his glaucoma specialty training at Eye Foundation, Nigeria, and then Arabian Eye Hospital in India. He's currently the head of department of ophthalmology, FMC Asaba, and also the head of glaucoma services. I don't want to preempt his lectures, but I know he has a lot to say. Chiba Kinyemi, over to you.
All right. Good day, everyone, all over the good afternoon, good morning, good evening, wherever you are listening to us all over the globe. I want to congratulate the Young Ophthalmologist Forum for setting this up. It's been a very busy week for everybody, celebrating the World Glaucoma Week 2022. And I think this is one of the last set of events that we are doing in order to commemorate the year, the World Glaucoma Week for 2022. So I want to thank the Young Ophthalmologists Forum for giving me this great opportunity to share this experience, interact with us on glaucoma services in Nigeria and how to improve it, where we are, the challenges, and the way forward. All right, I'll try as much as possible not to drag it, but at the same time, look at the essential things that we need to take note of, even as we move to the next level. A lot has been done already this year, and we hope that subsequent years we will be able to have better output in our services. Okay, I have no financial support or sponsorship, and there are no conflicts of interest. I intend to look at this topic today using the following outlines to define glaucoma and glaucoma service, a few historical background, statistics, where we are presently, challenges and bottlenecks, the way forward, conclusion, and then I will present the references. By definition, glaucoma is a group of disorders whose common feature is progressive degeneration of the optic nerve, with loss of retinal ganglion cells, thinning of the retinal nerve fiber layer, and increasing excavation of the optic disc, which gives characteristic changes in the visual field pattern. And as we all know, it has elevated intraocular pressure as a major risk factor. A lot has happened in the past few years in terms of the definition of glaucoma, okay, which has metamorphosed into what we have presently. And I will say that glaucoma services is talking about the constellation of activities, the events, the procedures that are there that are taking care of the glaucoma, even as a disease, either as a disease or the glaucoma patient themselves, and all of its related matters. Let's go through a little historical background about ophthalmological services and glaucoma. Glaucoma care in Nigeria dates as far back as the origin of ophthalmological services. And if I may say this, the inception of glaucoma service cannot be dissociated from general ophthalmological service. As a matter of fact, at the onset, the first set and group of people that were taking care of general eye care had glaucoma care incorporated into what they were doing. And so you cannot really clear-cut separate glaucoma care from the general ophthalmological care. And the Equa High Hospital Kano was established in January 1943. It's one of the earliest indigenous and dedicated eye hospitals that we have. And Sir Koforola Adekunle Abayomi was reputed as the first Nigerian ophthalmologist. So what I'm trying to say is that you cannot actually separate glaucoma. Every general ophthalmologist needlessly had to do with glaucoma care at one point or the other. And then the Department of Ophthalmology, University College Hospital, started as a unit under the Department of Surgery in 1962 before it evolved to become a department and what we have. And wonderfully, Professor Mrs. Oyewuyi and Professor Mrs. Ofutokun were the first set of registrars then at the University College Hospital, Ibadan, as far back as that time. And one of the ways by which we knew some people or some of these ophthalmologists that had bias for glaucoma was in the disposition of their write-ups. As far back as 1972, you can see this publication by Professor Olurin on primary glaucomas in Nigeria. Okay, even though majority of them might not have any specialized glaucoma, training, but in their general practice of ophthalmology, there was a bias that made them to be able to do a little more, research, a little more study, a little more training on glaucoma. Okay, as far back as that time. Professor Bodinier was the first indigenous professor of ophthalmology. Okay, and then other prominent Nigerians in the eastern part of the Maduluke, were people that had some special interest for glaucoma care. So the glaucoma care service in Nigeria has been on for a very, very long time, so many decades. Ophthalmological Society of Nigeria came into place in 1969, and then other prominent and very, very important names that I cannot but mention when we're talking about glaucoma and the history of glaucoma care in Nigeria with Dr. BGK Ajayi, and then our dear Professor Adeyinka Shaye. They have done so much, for this glaucoma service to become what it is in this present day Nigeria. Of course, the National Eye Center was commissioned in December 1992, and then we have some other indigenous Nigerians, working from that particular area in producing glaucoma service to the people in that particular region. Professor Samuel Amoni was a prominent name to consider from that area. Glaucoma still remains the second leading cause of blindness worldwide, because immediately after cataract, and is the leading cause of irreversible blindness, as we all know. The prevalence of blindness and severe visual impairment in Nigeria, according to our visual impairment survey, was 4.2 and 1.5% respectively. And the prevalence of glaucoma still remains as 5.02% in Nigerians 40 years and above. And interestingly, almost 90% of this group of people were not aware of the fact that they had glaucoma. Glaucoma-specific blindness prevalence in Nigeria is among those aged 40 years and above, is classified to be one of the highest ever reported. And that is something that we need to really, really get bothered about and see how much as we can reduce the burden of this blindness that is coming from glaucoma. And I think that's one of the major reasons why this is a major burner for us today to discuss on this service in Nigeria and how we can make it better in the subsequent years. Up to 20% of those that are affected with glaucoma were already blind bilaterally. That's disheartening. Okay, and the studies that were done at the onset were more on open angle glaucoma than the angle closure glaucoma. In fact, as a matter of fact, at the onset, the belief was that angle closure glaucoma was not a common occurrence amongst us, mainly because the rate of uptake of venioscopy examination was quite low. And so every case of glaucoma is classified as open angle glaucoma. But with modernization, with improved service delivery, with gonioscopy, we are now picking up a few of these angle closure glaucomas, and the incidence is coming up. Population-based studies and surveys of adults in Nigeria and Ghana as a comparison shows between 5 to 6 and then 9% respectively in those two West African countries. This is a map of Nigeria that is illustrating the prevalence of open angle glaucoma by geographic location. It's also an extract from the blindness survey conducted between 2005 and 2007. That is still the major tool that we are using as our reference for data of events and conditions in Nigeria, especially ophthalmology-wise. And it was found that from the survey, the lowest incidence that was found was 2.1. The lowest prevalence, sorry, was 2.1%. Okay, if we can look at this, we have 2.1% prevalence for open angle glaucoma, and that was found amongst the Yoruba community. And then the highest prevalence was 6.1%, which was amongst the southeastern parts of the country. 16.7% of persons with avoidable blindness is said to be from glaucoma, and the southeast region having the highest risk factors. I mean, the highest prevalence. The risk factors for glaucoma, of course, the cause of glaucoma is largely unknown, but we have a multifactorial interplay of both biological, genetic, environmental factors that all play one role or the other to produce the disease entity that is called glaucoma. The race is still something very, very special to us. It starts at a much younger age for us in the blacks, and it shows a more aggressive course than what we see in the whites. First-degree relatives has almost 4 to 8-fold risk of developing glaucoma, and that's why it is important for us to always check and see that every other member of the family, especially first-degree members, are also examined, they are checked, they are assessed for glaucoma if you pick up any member of that particular family. Ocular conditions, vascular diseases, secondary causes are part of the risk factors that over the years have been found to take care of. Now, a little bit of history on the initial services that we have in Nigeria. Don't forget, we are talking about glaucoma services in Nigeria, and this dates as far back as 60 to 80 years from the history that I gave. The main tools for the diagnosis of glaucoma then was more of pen touches and direct ophthalmoscope. We want to shine a pen light into the eye of the patient to check out for pupillary reactions. Okay, we want to check for relative apparent pupillary defects, and then the direct ophthalmoscope to look at the nature of the optic disc and then the optic cup of the patient. Nothing so much more than that.
I thought it's from me. So maybe there's some issues with the internet. Let's give him a few minutes to Can somebody, I'm trying to get across to him.
I'm not here to speak with you. I'm here to collect my money. Here for speaking. That time has passed. Time to
Sorry, we sincerely apologize for the technical issues. I'm sure it's being resolved.
Hello, can you hear me, please?
Yes,
Hello, can you hear me, please?
we can, sir.
We can hear you.
All right.
Okay.
Sorry for the network instability. I had to change some other stuff around here. Okay, so let's move on. So we're talking about the risk factors, okay, that has been established over the years for glaucoma diagnosis. All right, then we looked at the initial services. I was describing the chest tonometer that we used to use, and the drug use was mainly an issue of timolol.
Hello, sir, the network is.
Hello.
Can you switch off the video to make the bandwidth stronger?
Okay.
All right, thank you.
All right. Is it better now?
Yes, it's better.
All right, thank you. All right, so it was mainly an issue of those drugs we talked about, and less than 30% of the practitioners, whether the general ophthalmologist or the glaucoma specialist, were performing gonioscopy, and so that puts a limit on the diagnosis for us at that time. And then we have pocket and scanty surgical procedures done, for glaucoma at that onset when the ophthalmology, the glaucoma service was starting, and it was more trabeculectomy. Majority were general ophthalmologists, but it's suffice to say here that there were a lot of ophthalmologists that were general ophthalmologists at that time, but with great skills in trabeculectomy, which some of them have maintained over the years, and they're still working with them, despite not being a specialist. All right, that's just a picture of the chest thermometer that works with the indentation principle. Okay, we put all these weights over this particular plunger area, and then the deflection is read against a particular chart. Very few manpower all over the nation, not so specialized delivery of service, and then the chest thermometer that we described. Okay, that's an example of pen touch, direct ophthalmoscope, the perimetry, the confrontational type that we're having at that particular time. Now, that's where we started from. That's where the initial practice of glaucoma care started from. But where are we now, as at today, in Nigeria of glaucoma care? Where are we? Manpower availability, I would say that a lot has been achieved progressively in the past lots of has been achieved in programs which we shrink again, finding things here and there in order to make it a better practice. Local hands-on training organized by colleges, organized by institutions. Glaucoma Society of Nigeria, under the auspices of the OSN, has done a lot on this in the last few years. I can remember before the lockdown, before the 2020 COVID-19 issues, I think it was 2019, there was a Glaucoma Society of Nigeria seminar that was carried out in Lagos, and we had hands-on training on various glaucoma surgery techniques, under supervision, under guidance, which has really improved on what our people are able to produce and bring to the table. So that is really something that we must commend. In 2015, we have an estimated 232,866 ophthalmologists in 194 countries of the world, according to ICA. Now, there were weak inverse correlation between the density of ophthalmologists and the prevalence of blindness. That is expected. When you have increase in the number of ophthalmologists in a particular region, the rate of or the prevalence of blindness will definitely be lower, as opposed to when you have a reduction in the number or density of ophthalmologists. And the WHO recommendation of ophthalmologists per population is 1 in 250,000 in the Western world especially, and then about 1 in 50,000 population in developing countries. Is about 70 to 100, and that's even with those ones with either short-term certificates to full fellowships, whichever one you have. You don't have more than 100 of them in the final stage. So this puts a limit on the outputs that we can have nationwide. What about manpower accessibility? Apart from the fact that the number has increased a little, but there's still a little bit of reduction in access to those ones that are there. A lot of improvements, but majority of them are in the urban areas of the western and southern part of Nigeria. The southwestern part of Nigeria, the south part of Nigeria, the southeast part of Nigeria, whereas we have them a little bit less when you go up north from the central to the northern part of the country. But by and large, we have a lot more structured glaucoma outfits nationwide from the 6 geopolitical zones. But rural and northern areas are still largely uncared for till date. What about the issue of awareness? Awareness as of today, we are just celebrating World Glaucoma Week, okay? And it's been a lot of activities over the week. From Sunday, even some institutions, organizations started their celebration before the Sunday that the week was supposed to start. So World Glaucoma Week has been celebrated over the years. And this has given a lot of publicity to what glaucoma is all about, whether in the print media, in the social media, radio and television broadcast. A lot is being done annually, through the World Glaucoma Week. And then the World Sight Day over the years has also been celebrated. And incorporated in World Sight Day is also a broadcast or making of a noise about glaucoma for people in our community to understand what this is all about. Another point that has also helped with awareness is Glaucoma Patients Association. This is a group that is functioning in, a number of parts of the country, a number of institutions in the country. Okay, we are aware of Lagos, we are aware of Kaduna, Port Harcourt, also some other parts in the north, and then some other western parts of the country where glaucoma patient associations are functioning very, very well. This is also a way of improving the awareness of not only the patient, even their first-degree relatives, their members of family, and then they are also able to release the message about glaucoma to their communities and so spreading it. Like I said before, plenty and so many write-ups now, flyers, jingles in different languages. In fact, there are jingles now about glaucoma that has been done in all the 3 major languages of Nigeria. Even some other minor languages are being translated into some other minor languages in the country. The Glaucoma Society of Nigeria has a Gmail account now. They have a Facebook page, they have an Instagram page. These are all modalities of improving the awareness of the population, okay, in terms of what glaucoma is all about. Now, I want to look at making a diagnosis of glaucoma. We are looking at the various segments or the various aspects of glaucoma service and where we are today. We look at the challenges and then we look at what can we do to make it better. Glaucoma is more than just a one-time intraocular pressure measurement now. Okay, it started as that. We want to juggle things around intraocular pressure, but now we're looking at the issue of target pressure. We're looking at tracing, in intraocular pressure measurements. There is no one particular intraocular pressure that you can say this is normal. Even though we have a range of between 10 and 21 millimeters of mercury, but the pressure at which the damage that you expect for that individual is halted is what you want to target at and work with. So it is individualized. You are taking each patient one at a time, and then you are tailoring the treatment and the modalities of management to the individual need of that particular patient. A lot of different tonometers are now available. You know where we started from. I showed you the picture of the chest tonometer initially, okay, which was not very, very comfortable. The patient has to lie down. You put a local anesthetic agent. You have to put an indentation device over the eyes, to be able to get all of those done. But now we have a gamut of so many different types of tonometers. The Goldman applanation tonometers, the IKEA tonometers, the Perkins tonometers, all brands of non-contact tonometers are available now. I'm still talking about the equipment for making a diagnosis. The slit lamp biomicroscopy with a plus 60D, a plus 70D, or plus 90D stands as a gold standard for our diagnosis. Now, it gives us a better analysis, a better description of the optic nerve head and then the optic pop of the patient that we are dealing with. And so we're able to make a three-dimensional description of the disc. It gives us a better idea of what is happening there in that particular patient. Of course, we talked about gonioscopy earlier on. Many people were not given to that, but it's improving in terms of how many persons, how many ophthalmologists, how many glaucoma specialists are doing gonioscopy, whether the direct one or the indirect one. Then don't forget again that the good knowledge of gonioscopy also is what is being employed now in the various angle devices and angle surgeries, the minimally invasive glaucoma surgeries that are being done right now, so which has opened up the scope of what we can do in the management of our patients. Yeah, ultrasound biomicroscopy for detailed angle analysis, pachymetry in cases of normal tension glaucoma, ocular hypertension. We're able to decipher that, okay, is this actually glaucoma or is just some other issues with the corneal thickness that is affecting the intraocular pressure that we're coming around with. Now, what about the skills in terms of the people that are able to pick up this particular glaucoma condition that we are talking about? Trained manpower. Nurses have been trained at different quarters, both locally, internationally, and then in our remote areas on the ability to be able to pick what can be a suspected glaucoma case just with their pen touches. A lot of training and acquisition services are rendered by nurses. And then in some institutions like ours here, we have family physicians coming for rotation in ophthalmology for 1 month, and then we have public health physicians coming around for 2 weeks. That has been incorporated into their training. One of the major things that we do when they come around like that is to show them the important things you need to recognize to see that this is a case that is likely to be glaucoma, this is a case that is likely to be cataract, and then they refer them to us appropriately. Of course, the treatment and the management of glaucoma started from general ophthalmologists, so we cannot underestimate the importance and the significance of general ophthalmologists in glaucoma care till tomorrow. And then we'll talk about the specialist glaucoma trained individuals. Visual field analyzers. We started from the kinetic perimetry. Now it has been blown out. We have the standard automated perimetry. We have the shortwave automated perimetry. We have the FDTs, that are now looking at the the minute details of those ganglion cells and able to pick out even the damages quite early with different threshold strategies and programs and better reliability indices in them. Now, I want to also look at other devices that are used in analyzing the nerve fiber layer damage that we see in glaucoma patients. When the OCT was first introduced in Nigeria about 20 years ago, a lot of people had resistance to it because of the cost. Okay, in fact, it was a form of exploitation for our people. They have to pay as much as 50,000 back then, 100,000 for a device that does not treat, does not remove the glaucoma from the patient. But over the years, it has been more acceptable because it gives us a more objective assessment of nerve fiber layer damage, and we have a better diagnosis of glaucoma in this case. There are a lot of patients that might have a CD ratio of up to 0.8, and yet it's not glaucoma. It might just be a physiological popping that we have in such patients. OCT has given us the opportunity to be able to differentiate such cases. Pre-perimetric stages are picked, it's reproducible, sensitive, it's good for follow-up, it takes care of overdiagnosis, and we have a better acceptance of OCT now than what it used to be. Of course, cost is better than what it was at inception, but still a factor to consider. We also have OCT angio, and then the glaucoma disease nerve fiber layer analyzer, and the Edinburgh retinal tomography, which are also devices that are used to assess the nerve fiber layer and give us a more robust assessment of the optic nerve head. All right, those are just representation of the OCT on the left, and then to my right is the GDS. Now, fundus photography for baseline diagnosis and follow-up for patients is also there. Of course, it's not limited to just the eyes alone. We know that the optic nerve is an extension of the brain. So magnetic resonance imaging assessment for ischemic and compressive optic neuropathy, small vessel disease of the brain, and even generalized cerebral atrophy for those that have vascular components to their glaucomatous damage. So it gives us a whole robust idea of what is happening just beyond intraocular pressure measurement, which was where we started from. Oh, talking about medical management of glaucoma, this is an area and an aspect that has gone so wide. Medical management of glaucoma still remain first line in most quarters in the country for so many reasons. And now we have much more available varieties of drugs and combinations of drugs, okay? What this does is that it makes it a lot easier for patients to comply with your drugs. Some of them are just once in a day, the prostaglandin analogs. The patient can just take it only in the night, so that the issue of I'm forgetting the drug, I don't have time, I left it at home, I didn't go to work with it, is taken out of the place for the patient. And then so you have a variety of them. You can combine 2 eye drops together in one single bottle, to give maximum effect for our patients. It makes it a lot more convenient for them. We have the preservative-free, medications and eye drops, which reduces the ocular surface disease that we have in these patients and many other complications that we can have in the benzalkonium chloride, which is a regular preservative that we have in most of our eye drops. And a number of different drug companies are coming up every day with the intention of trying to beat down the prices of these drugs. You know that the drugs are still quite expensive, but a lot of work is being done every day, by different drug companies to ensure that we have the reduction in the prices of these drugs. Of course, we have some newer drugs, the urokinase inhibitors, the latanoprostene. Some of them are not here in this country, but we have patients that are coming from overseas, and they are coming with these drugs for us. They are quite expensive, like you see. A bottle of Repressor is about $360. That's something that will still be a bit far-reaching for us in our society. So for medical management, affordability, counterfeit drugs, adulterations, cold chain issues are things that we're going to be looking at as challenges for us. Now, surgical management of glaucoma made tremendous progress in that aspect. As a matter of fact, we can now train glaucoma specialists in Nigeria. That was not what was what we had before. Okay, you have to travel out, travel abroad to do the training, but now there are centers in the country. Eye Foundation as a major point, for better training, more trained hands are available now, and there are improvements in confidence of the patient. Of the surgeons. A lot more people are delving into trabeculectomy and other surgical procedures that we have. I can remember last year glaucoma subspecialty day of OSN. It was trabeculectomy demystified. That was the theme of that particular seminar for the glaucoma subspecialty day, and we looked at different aspects on what we can do in order to help our surgeons, our ophthalmologists, to pick up trabeculectomy a lot more than what we have been doing, and many more people are doing this all around the globe, all around the nation now. So trabeculectomy is there. Traditionally, over the years, it's been there. Okay, but we have the use of 5-FU, the use of mitomycin C now, okay, in order to reduce the fibrosis that happens post-operatively. Trabeculectomy procedures are there. The use of releasable sutures, which help us to be able to adjust the intraocular pressure of the patient even after the surgery has been done. A lot of blood review surgeries, and then the glaucoma drainage devices and tubes is happening here right in Nigeria. A lot of centers in Lagos, but some other places also are going into glaucoma drainage devices. As a matter of fact, I'm even also reliably informed sometimes later this year at Ijebu Mushin Eye Foundation Outpost, there's going to be a training also for tubes for some close group of people, ophthalmologists in Nigeria. So it's something that is moving on every day, improvements every day, in order to be able to make the service that we are rendering to our people a lot better. Of course, minimally invasive glaucoma surgeries are available in pockets of centers nationwide. I remember, I think 2 years ago or so, 2019, there was a presentation by one of our doctors on the use of phycoprolene for GATS in Nigeria. That's in Lagos then. So these are things that we don't think that is just outside. We are getting people, individuals, trained to be able to perform this procedure right here in the country. And then for pediatric surgeries, this is usually between the glaucoma specialist and pediatric ophthalmology. So we have, like, from the two different sides, the pediatricians are doing it, the glaucoma specialists are doing it, and so a lot more can be done in terms of that. Then I'll look at the laser management of glaucoma, a lot of improvement and a lot of widespread nature to it. As far back as many years now, Professor Babolela in Abuja did a lot of work on the lasers, okay, and that has been taken to some other level right now, by Professor Abdul, which is continuing every day. Argon laser trabeculoplasty is happening in Nigeria. Selective laser trabeculoplasty is happening in Nigeria. Diode laser trabeculoplasty, YAG lasers of different kinds, endolaser procedures, and then the diode laser micropulse or continuous pulse is also going on at different locations and different centers all over the country. In some contexts, it has been advocated as a one-stop treatment modality for patients, okay, for so many reasons. Some believe that, okay, if you consider the cost of the medical treatment, the apathy of patients towards surgery, so you might just have to look out for a laser procedure that can give you something that is repeatable, less invasive, give you some degree of result that you can even, work with at a cheaper cost for the patient, compared with all the existing modalities that we have. So we've had a lot of improvements in our laser procedures. Now, apart from all those core treatment modalities that we have, counseling is something that has also been improved upon.
Sorry for the internet itches. It's trying to reconnect.
Hello? Hello, can you hear me now?
We can hear you.
All right, sorry for the network issues again. All right, so we were talking about the counseling done for this patient. You need to have a balanced information on the various aspects of management before they deliver it to the patient. So they need to be properly trained. And then you're looking at the anxiety, the depression, and suicidal tendencies that we have in our patients because of the fact that they okay, so we to the appropriate trees, and I want to look at how well they can help them out to come out of whatsoever form of depression or suicidal tendencies, anxieties that they might be having. So at one point or the other, there may be need to refer these our patients to the psychiatrists, okay, the behavioral medicine people. So that is also something that is going on now, which we are taking up so seriously. And then in the rehabilitation of these patients with advanced glaucomatous damage, with loss of vision of different degrees, it's also important to note that there are various centers in the nation that are even training people on low visual devices. Okay, they are training ophthalmologists, they are training fellows, in low visual devices that can get back to your various centers and utilize. So low visual care is a lot more robust now than what it used to be. And that helps in helping the patients to adjust to the activities of daily living. They're able to get themselves incorporated into their society, and make something useful for their lives. Right. In the midst of all of these stops that we have presently, a lot of advancement has been made, a lot of progress has been made in the past 30 years, in the past 50 years, of glaucoma service in Nigeria. But we still have a lot of challenges that we are confronted with that we need to work out and work at in order for us to get to the next level that we expect in our glaucoma care. Manpower availability and distribution is still an issue. Okay, at the beginning of the presentation, I gave us an outline and estimate of the distribution of where we have the ophthalmologists in Nigeria, the density of them, and then in the total number of ophthalmologists, before we talk about the glaucoma specialists, maldistribution and reduced availability. So that is something that we need to look at. How can we make it better to increase the number of ophthalmologists that we have to start with, and then encourage as many people as possible to go to glaucoma care. I've also heard it from some other quarters that no, glaucoma is not interesting. Why would you want me to go into a specialization that you don't have so much hope for the patient? The patient is not going to see. The patient is eventually going to get blind one day. Why would you want to do that? Let's go to something that is more exciting. You can do something and you can see the outcome, come out to limelight for everybody to see. So we need a lot of mobilization to help people get more into this. Now, the awareness and accessibility to specialized care is also a factor to consider. About 80 to 90% of those with glaucoma seek medical attention at the late stages of their disease. Okay, so late presentation, late diagnosis is a major challenge for us. A typical glaucoma patient might be coming from the rural areas, already blind in one eye or in both eyes, and then not even having the major caregiver to support the majority of the treatment modalities that you want to give onto this patient. The stress of management, of medical management, is still there. Okay, even though we have made some improvements in trying to beat down the prices, in trying to reduce the frequency of dosage and all of that, the issue of adulterations, affordability, and the cost of the drug is still there. I know that some glaucoma patient that spends up to 12,000, 15,000, 20,000 in a month, okay, for their drugs. What's the minimum wage in Nigeria? How many people can afford that? So it's a major, major challenge for us, even though the patient is willing to comply with your regimen, but yet the modality and the resource to do that is not there. Storage, application modalities, the side effects of the drugs, the back-free medications are quite expensive. Daily drop application, you have to keep on using this eye drop for the rest of your life. There are major factors that contend with, the management of glaucoma in our patient. How about the surgical management? There is apathy to surgery by the patient. You are telling a patient that, okay, you have glaucoma in your eyes, I'm going to operate you. The essence of the operation is not to make you see better, but to help you to reduce intraocular pressure. And then I'm going to work on your better eye, rather than the eye that you think is not seeing well. So you need a lot of counseling, a lot of explanation to do, on the part of on your own part as a surgeon for the patient to be able to accept it. And I want to say this, that it depends also mainly on the way we present it to the patient. We want to remove our mind from the issue of, okay, it doesn't improve vision, so just stay with your eye drops. No, there are a lot of patients that will still benefit a lot from surgery. So we want to encourage us to keep on talking and selling this surgical management of glaucoma to our patients, okay? So that we, the surgeons, are not afraid of doing the surgery ourselves. There will be challenges along the line, okay, but we need to be bold about it. That's one of the major reasons why last year we talked about trabeculectomy demystified, with the intention that at the end of that seminar, everybody from different quarters all over the nation will be able to have a better output of their glaucoma trabeculectomy surgeries, especially. Okay, so both surgeons and patients needs to be encouraged to get a better grip on what to do in terms of surgery. Laser management of glaucoma is a challenge. Even though some people have this, have advocated that it should be the major line of management for a patient now, it is still quite expensive. A lot of them are still quite expensive, 50,000 naira, and in the neighborhood, some of them are even more than that. Inadequate distribution of where to get them. Okay, that is still a challenge. A lot of systemic bottlenecks. We are ready to do what we want to do. We have the facility to do them, but electricity failure in our country is still a major challenge. Okay, the running of the clinics can be very, very uncomfortable even to run the normal clinic for glaucoma or whichever clinic you're running because of power failure, high cost of private power generation in hospitals, hospital management complaining of how to generate diesel. You can see the first scarcity that we've been having for the past few weeks. Going to 1 month and more in this nation. So it's a whole lot of systemic problem that reduces and creates so much challenge for us in the management of glaucoma. Industrial actions, whether by doctors, by JOHESU, by different groups and organizations in the hospital. All of these create a major challenge. COVID-19 came with its own problem in 2020, and then we are still trying to recover from all of that effect in terms of examination challenges, and theater list cancellation and all of that. So many systemic issues are there for us to grapple with. Loss of medical record for effective follow-up is still another major issue, especially in majority of our centers where we still use paper for consultation. Okay, so we are looking at how can we surmount some, if not all of these challenges that we are confronted with. And then we look at the way forward. Where do we go from here? How do we go from here? We want to improve on the service that we render to our patients. We want to improve on the output of what we can do. We want to improve in the distribution. We want to improve in the skills of the providers. We need to be conscious about this. We need to be dedicated to it. We need to be committed to it. Otherwise, we'll just be talking and then there will be much progress that we can have. So I want to look at it in this particular aspect. We need an improvement in our awareness. Now, a lot is being done on that already. All we need to just do is to make sure that we keep the tempo as high as it is. This year was wonderful. Last year was wonderful for World Glaucoma Week celebration. We need to keep up the tempo and make sure that we even do it better. Every nook and cranny of this nation, every print media, every social media handle available, we must make noise about this glaucoma, let the people know what is happening, know the complications, know the problems that can arise from it, and then know where the people can go when they come down with this particular problem. So we need to improve on that and sustain what we have already. Improvement in manpower and equipment is a major factor for us now. Glaucoma is, ophthalmology practice is a practice of equipment and instruments. Okay, without it, we cannot do so much. We cannot meet up with our partners all over the globe. So partnerships, sponsorships, and collaborations are one of the ways by which we can get this done. Government alone cannot do it. A lot of things that the government cannot do alone in Nigeria now. So we need individual bodies, private establishments, whether government or non-governmental, to come together to help in various aspects of glaucoma service management. Fellowship programs for glaucoma specialists, it is still quite expensive. Luckily, we have some areas in the country where this fellowship can be done. A lot of people, it is still quite expensive. So where we can get people to sponsor it, whether individuals, hospitals, organizations, collaborations to do that. Training more ophthalmologists in laser treatment, apart from even glaucoma specialists. Professor Abdul is doing that. A lot more can also be done. I remember sometimes last year or so, was invited to our center to come and give this training, and after which we started picking it up. Some of these things can be done and become and be intensified all over the country. And then in the purchase of equipment, consumables, drugs, and then subsidized surgeries and procedures, partnerships, sponsorship, and collaborations will also go a long way to making it better for us. Somebody has also suggested from another quarter that we can organize regional surgical training and mentorship. What I mean by that is that you can look at the South-South zone, you can look at the Southeast zone, the Northwestern zone, look at areas or institutions where some of these surgical procedures are better done. We get a center there We look out for ophthalmologists in that particular region or locality. We organize a 1 week thereabout surgical training for them. And then from there, you can monitor them, mentor them to be able to be more proficient in what they can do. That can be done on a regional basis, either through Glaucoma Society of Nigeria or Ophthalmology Society of Nigeria as a whole. With that, we'll be able to improve on the manpower availability and the confidence of our surgeons in bringing and coming down with this surgical procedure. Glaucoma Patient Association in the past few years has been improved upon. We have some established centers across the country, but this can also be better. What are the advantages that we have from these GPAs? They can provide alternative and supplementary sources of funding. There are sources, funding for drugs, procurement, surgeries, funding for surgery fees at a discounted rate, the first degree relative assessment, information dissemination and support groups. All of these are things that the Glaucoma Patient Association can help us to do better. And I remember that Glaucoma Society of Nigeria, the present set of executives, sometimes last year, started working and getting templates from all the various areas all over the nation where this is working well, in order to create a template that other centers that are not doing it right now can key into it and make it more robust for us to have as a general thing. Of course, this is also going to require a lot of sponsorship, which the society is also working in. And I believe that at the right time, when it is mature, it will be released out for us so that wherever you are, in any part of the nation, you can have the templates to follow to establish this Glaucoma Patient Association and then have all the advantages that are locked therein. Now, we want to also suggest, as has been advocated as supporters, that maybe possibly we go on for lasers. Okay, this diode laser, that the micropulse or the continuous diode laser cyclophotocoagulation, in order to reduce the issues of medication poor adherence or the poor acceptance of surgery. Laser as a one-off treatment for glaucoma care in Africa has been advocated. So we want to see whether we should look at that and reduce the cost of drug treatment and then help our patients. It's repeatable, we can do it. If it fails, we can repeat it again. Maybe we can go through that particular line and see how that can help us out. And then the need to incorporate local context to what we do is very, very essential. There's the glaucoma toolkit that was launched recently, okay, which helps us to be able to have a centralized, coordinated way of managing our glaucoma patient. The need to have larger randomized control trials is also being planned, okay, to provide evidence for clinical services through guidelines and protocols, and so inform national policies on how to go. I will talk briefly on this genetic issue of glaucoma, the eye of Africa, the genetics of blindness in sub-Saharan Africa. That's a collaborative study between the University College Hospital Ibadan and the Duke University Medical Center in North Carolina, USA. Of course, the UCH Ibadan is also getting samples from other centers all over the country, spearheaded by Professor Ashai. I want to say that Professor Ashai has been at the forefront of genetics of glaucoma in Nigeria for so many years. And presently, this is a baby project. It's a 5-year project. It's gone to like 4 years now. I think this should be the 5th year of collecting samples in order to identify the new susceptibility genes for primary open-angle glaucoma in order to be able to lay the foundation for novel therapeutic intervention. We have the genetics of glaucoma from the white, but we want to look at what are the peculiarities, what are the peculiar genes that can be, worked with within the sub-Saharan African regions and then give us better therapeutic interventions for our people. So this is a laudable project, which I believe that the preliminary results was presented, I think, last year after the first 3 years. And then by the end of the whole 5 years series, there's going to be a final presentation and report that can help us to have better intervention. Of course, it's also to conduct targeted glaucoma screening in sub-Saharan Africa. Loss of medical records in some quarters, so people have advocated the use of electronic medical records. EMR is getting a bit more public, a bit more popular in various areas. Now, this will help us to have detailed and more sure recording of information. It will also facilitate data collection for research. Holistic glaucoma care team is also being advocated, not just the ophthalmologists, not just the glaucoma specialists. We want to include the nurses, the counselors, the psychiatrists, in order to give a whole, a holistic care to our patients with glaucoma. All right, so in conclusion, this present now, I would say that glaucoma care in Nigeria has passed through a lot of processes and development since its inception over 60 years ago, both in terms of the various modalities of diagnosis, in terms of the management of the patient, the follow-up, and the rehabilitation. And Nigeria being a developing country, lack of awareness that leads to late presentation, maldistribution of manpower, and the gigantic cost of services, in conjunction with systemic failure, remains major factors to grapple with. And governmental and several non-governmental collaborations to bring down the cost of services and training, efficient and ably funded supported Glaucoma Patient Association, coupled with committed and dedicated transfer of skills from established glaucoma practitioners to the upcoming ones, will go a long way in improving the quality of glaucoma care that is rendered in our country. I want to thank you all once again for your time and your attention for this presentation this day. And my special thanks will go to the Secretariat of the OSN and also the Secretariat of the Glaucoma Society of Nigeria. Well, I will now feel to appreciate my mentors in glaucoma care in the country, especially. Thank you so much for all the insights in making this presentation what it is today. And these are my references. Thank you very much, everybody.
That's wonderful. Thank you very much for this very good presentation. You can see he has really gone to town telling us about the history of ophthalmology in Nigeria, the glaucoma services, where we were, where we are, and the way forward. So I have my few questions, contribution, but let me see what we have from the audience. Somebody is asking if you can share the result of the preliminary report of the genetic study in Sub-Saharan Africa. And the person has given an email. So,
well, I don't have it here. I'm not sure.
I think something. I think it's something that can be browsed online.
Yes, it's online. Dr. Shola Olawe is prominently assisting Professor Ashai in that project. And there was a report last year. I don't have it here right now, but it's something that you can get online. If I get the link, I can also pass it across, maybe later to the Secretariat of BioF for onward release to the person asking the question. It's available, very, very much available.
Okay. So I've not seen any other question. Maybe there are. Okay, people. Okay, let me ask a few questions. Okay, you see, let's go a little bit practical. Now, looking at our residency training, the structure of our training vis-a-vis the glaucoma services we provide, is there anything missing? Do you think that is there anything missing that we need to be, because residents are the one that would ultimately become consultants? Okay, let me just go straight to the point. You see, we participate in the update course. I will look at the lecture schedules, especially the one under glaucoma. And I believe, okay, I participate in both West Africa and National Update course. So I see the topics being discussed there. But in my own opinion, there is something that is lacking there. We need to promote protocol-based management of glaucoma. Everywhere in the world, glaucoma is being managed based on protocols, evidence-based. If I have this patient, he has this is what I'm going to do. If I have this, if he has this is what I'm going to do. Okay. Dr. Kinyemi, do you think if we incorporate that, will there be any? Hello, are you there? Okay, he's not there. But basically, what I'm saying is that we need to do more in our glaucoma education, especially at the level of our residency training. It's not just enough to know that yes, POAG is POAG, and diagnosis of glaucoma is with IOP, CVF, and optic disc. Patient has pressure, continue this medication. So what if the patient comes? So if you have a patient with glaucoma now, you have to know, this is my plan A, plan B, and plan C. So that art of management, in my own opinion, that is what is lacking in our training. And that is why patients will be coming over and over and over. You can see that the same thing is being repeated because we are not following any protocols in managing the patient. So I think there's need for us to inculcate protocol-based management of glaucoma patients in our practice. And even basically there are ICO, AAO, and recently introduced, okay, he's back, okay. So can you hear me?
Yes, I can hear you.
Yes, what I'm saying is that I'm talking about issue of protocol-based management of glaucoma using either the recently launched this toolkit for glaucoma care, ICU, and other things. Don't you think that part of glaucoma education is missing in our training and practice? Because most of the time when you see patient is coming every day, there is no definitive plan, plan A, plan B, plan C, like that. So don't you think that's another gap that we need to address as trainers, and we also encourage our residents to be doing that?
Yeah, you are very, very right. You're very, very correct. Because what we need to do is to have a protocol of management. By the time a patient is coming, the state at which you are meeting that patient, you must have a plan for that patient. And that's why the glaucoma toolkit, okay, that was recently launched, gives a guideline on how you should manipulate or maneuver any kind of patient that comes your way. So I want to say this, that for all of our training centers, both for the glaucoma specialists and then for the general ophthalmologist, any clinic where glaucoma has been treated or managed, there should be a protocol on what we need to do for those patients. And it's something that should be standardized. I remember that some times ago, the Glaucoma Society of Nigeria also put forward something like a master plan for management. I'm not too sure of how far that has gone now, but I think with the glaucoma toolkit is something that is now more encompassing. So I want to encourage all our trainers, if you don't have access to the glaucoma toolkit, something that we need to look at and see how we can adapt it to your particular local setup for that patient. By the time a patient is coming, you have an idea of what is your treatment plan for this patient. You are meeting a patient that is having mild disease. What is your target for this patient? The patient that's having a moderate disease and advanced disease, what's your target for this patient? What are you aiming at? And that is something that must be clear to all the care provider from the onset, so that whether the person that admitted, that saw at the first site is there or not, somebody is carrying out that same, protocol of management for such patient. So that's something that we need to also put and work with, especially with what has been provided in the glaucoma toolkit. Maybe there might be a need for us to do local hospital-based assessment of what you have been doing, and then how can we make it better to have a protocol for our management and managing our glaucoma patients.
That's a good one.
Yeah, I saw a question on the platform on keying into disability days also. Okay, there are disability days that are being celebrated worldwide, nationally also. So we can move in and join them in also discussing and making noise about our glaucoma on such days, and not just limit them to only World Glaucoma Week and World Sight Day. We want to try as much as possible to see how well we can make so much prominent noise about this glaucoma and how to go about it.
That's good. Okay, somebody's raising his hand. Magdalene, you can.
Okay, good afternoon, everybody. And, thank you for the great presentation. Just to follow up on the last contributor's conversation, it's good for us to adopt the protocol or guidelines for management. It's also important that we collaborate with centers that have things that we do not have.
Yeah.
This comes very handy where you are in a public institution where all the equipment are not available.
Yeah.
And you access this patient. The patient is not yet agreeing to having surgery. The cost of the first line drugs are probably out of reach. This patient could benefit from laser. There's no laser in your institution. It's just good for us to reach out and encourage the patients to go to other centers so that at the end of the day, we have more effective service delivery being rendered to the patients. I'm not too sure of how many centers are doing what Dr. Abdul is doing in Bauchi State, but it's yielding results. It's something that we can adapt for, I would say, most of Nigerian patients, particularly for those who are in the low income bracket. And so where we know that those things are existing, it's good to offer those services to the patients. Thank you.
That's very good. Let me see any other question. Sorry, I shared the glaucoma toolkit in the chat box. If you can actually get it from there. So there are no other question here, but Dr. Akinyemi, we all believe that trabeculectomy is the mainstay of glaucoma. It's the gold standard of glaucoma surgery. And you can see it doesn't cost much. You don't need, not like armored glaucoma valve that you need to get the valve and some other things. But still, very few people practically are doing trabeculectomy in Nigeria. I practice in the north. I do go to other hospitals and I know what I'm thinking about. How do you think we can improve surgical skills? How can we? I think the problem, I have a little different opinion. The problem is not only the patient, but also the providers. You understand? If there's a way you talk to the, I tell my patient, you have glaucoma, you need surgery, and that is the only thing that can bring the pressure down, and they accept. So of course there are some people that they reject. So now the question is, how can we improve the surgical skills of our doctors, ophthalmologists, and the resident apart? You talk about an important point that I really like, this regional surgical training and mentorship, which is quite good and is something that we can really explore. But in your own opinion, how do you think we can?
All right. Like you said, a lot of time it's not just the patient, it's the surgeon.
Yes.
The surgeon himself might not even be confident to do it. And that's why you need somebody to hold your hand to be able to get strong in what you are doing. I remember on a number of years ago, we've done trainings at the Glaucoma Society of Nigeria platform when we had one of these early in the year meetings. Now, you need the boldness to launch out and do it. Majority of times, I talk about regional trainings. Maybe the people that are in South region, you have a center where trabeculectomy is being done regularly. You are a glaucoma specialist or you're an ophthalmologist and you're interested in trabeculectomy. Okay, it can be organized. You can gather your patients together. You have 2, you have 3 patients that needs trabeculectomy, and then you invite such a person to come to your center and come and do. He's putting you through, he's staying with you to do the follow-up, and at the end of the day, you are a bit more confident in what you do. This thing is mainly about confidence. If you are not confident about it, you are the ones that will even be discouraging patients from taking that option. And that's what has been happening a number of times. Okay, you tell them there are many options available. You can use eye drops, you can do surgery, even though the surgery will not make you see better. Once you have said that to the patient, you have already discouraged the patient from taking the option. So there is no difference between medicine and surgery. So why do I need to do surgery? And then I'm not doing the surgery to make I see better. So it depends on how we portray it to the patient, how we sell it. It's like a service that you are selling to the patient. If you sell it with a bias at the back of your mind that I'm not going to do it, the patient will not take it up. But just like you said, oh, we have glaucoma, you will need surgery for this eye to maintain the pressure, and this is how it's going to go. And the patient say, fine, docs, let's go ahead and do it. So mentorship is a very, very important aspect of it. I remember when I started my case, Dr. Ogoro in Lagos was so handy for me. Okay, she helped a lot in most of those teaching time in performing the surgery. Any little complication, anything that is gray, that is not clear, after we did the training at Fire Foundation those many years back, and from there till tomorrow, consultations are still being done. So you need mentorship in this thing. Find a place that you're comfortable with, especially within your locality, where you can have training and retraining. There are no 2 ways to it. You must be trained properly on what to do. You must know the techniques, you must have the skills, and then the confidence builds over time.
Chuma, she has been raising her hand, so.
All right.
Yeah, hello. Good afternoon.
Afternoon.
Yeah, I'm happy to be here. Thanks for the very good lecture. I was just trying to emphasize the need for education. Yeah, it's important to treat glaucoma and all of that, but I think it's also very important to prevent it. So, and one of the ways to achieve that is through education, by telling people, letting people know what glaucoma is. This is something that happens when the pressure in your eye increases. So I was just wondering, like, if there are ways that that can be done on social media, like creating all those short videos, or using icons to really kind of pass the message, because even among young people, even doctors, a lot of us don't know our eye pressure. That's the simple truth. And if we don't even know, if all of us as doctors, a lot of us as doctors don't know our eye pressure. So you can imagine what the general population, what it would be like for them. So I think for us, instead of just waiting, when is what glaucoma week, we'll come talk about it, and then we go to sleep and come back next year, and then come back next year. So I think we should actually make use of the social media, WhatsApp platforms, Instagram, all of those places. And then we pass on this information to the young people, because these young people, if they prevent their eye pressures from increasing, they'll be the ones that will go old and still come as our patients. And these people also have a way of talking to their friends, their peers, their families. So the importance of social media in kind of passing on this information is very important. And I think is a tool that we can utilize. It's not something you're going to pay. I mean, your Instagram page, WhatsApp page, you have people like an Aproko doctor passing on a lot of information. And you can find a way to make it fun. Because we go telling people, check your blood pressure, check this, even the blood pressure issues. People don't even check that blood pressure, something they can do in a small place, much more about their eye pressure. Someone like me, I've just gone to check my eye pressure just once, like early this year, because I needed to get my glasses on. I mean, I've been living for more than 30 years and I've not even done that. I've just done it for the first time this year. And I think it's important that we pass this message through the social media, and that's a very good tool that we can use. And I don't think we should wait till when it's what glaucoma or what sight week, and then we start talking about it, and then we go to sleep again. Everyone, if it's something, you can say, okay, every month I'm going to put a nugget on my page, on WhatsApp, Facebook, and all of that, you'll be passing a lot of information, and you get to prevent this or even catch it at an early stage, and not when the patients come and they can't even afford care. So that's what I was thinking about.
That's
Thank
a
you.
very good one. That's a very good one. So still the thinking about issue of counseling, how we counsel patients with glaucoma. Do you think the counseling also affect acceptance of surgery?
The counseling for what now, please?
Okay, you have patients, somebody has glaucoma, needs surgery and all that.
Okay.
The way we talk, don't allow anybody to touch this eye.
You can play.
This eye, you are going to lose your sight. I have a patient who have been battling with him to accept traveling. Why? Because he has already been told not to allow anybody to touch that eye because of wipeout syndrome. So.
Oh, okay. Okay. Well, all of that is why when I was talking about counseling, I said we need proper training for the people that are going to do the counseling, because a number of times you as the surgeon in the clinic, you might not have all the time to explain all the details of what it entails. And that's why the people that we're going to dedicate to do the training must be properly, to do the counseling, must be properly trained themselves on what to say. Well, wipeout has been said to be there, but we also know that in some other quarters, we've been told that you can do one or two things, to be able to prognosticate whether that particular patient is going to have a wipeout or not, depending on the macular vascularity and all of that stuff. So these are informed decisions based on investigations that we have done. You must prepare your patient for surgery. Every patient is individualized, okay? Before you have made up your mind that this patient is going to have a surgery, you must have made up your mind that, okay, this and this and these are the things that I want to achieve. Whatever the patient is coming with from wherever he has gone to, a lot of malinformation, you must be able to disabuse the mind of the patient about all of such things and let him know that this is the real thing that I'm seeing in front of me and which I want to plan to do for you. So I think we need to be up in our game in terms of our communication with the patients. And then if we are going to delegate that duty to anybody, the person must also be properly and well trained in what to do. And then talking about what our last speaker contributor mentioned about social media, and I think that's very, very wonderful. Luckily for us now, even from last year, it was compounded again this year, a lot of clips, videos, as jingles and what have you that we can use to publicize and educate the society about glaucoma. So we need to be committed, we need to be dedicated and intentional about this, that we want people to learn about it. Glaucoma is an irreversible cause of blindness. That means once it is done, it is done. Okay, so that's why we want to pick it as early as possible before the patient gets to that particular stage in which is not redeemable again. So that education is important. I want to encourage everybody on our various social media angles. Let's see how we can just release all of those jingles, all of those videos, all of those leaflets, flyers, and write-ups, to just educate the society. I saw Dr. Ajayi made a comment initially. Want to appreciate her for being here. Then I also saw that Dr. Regina Morgan is here. These are elder state women in the house, which I think we would like to have their one or two words of encouragement on this topic. And, yeah, before we think of
Professor Morgan, ma'am. Hello?
earlier on. Maybe she's busy now.
Okay. Honestly, this issue of regional training is something that we really need to look at. Because when it comes, anytime issue of glaucoma training is discussed, I always keep examples myself. Before my fellowship, I couldn't do trabeculectomy. I have never done trabeculectomy before I went for my fellowship. And after just 1 year training, 12 months, I can do trabeculectomy. If you can multiply this thing in Nigeria, do more and more and more and more and more and more training. And the more you do, the more confident you actually become. And then another area, in my own opinion, that is a big problem for us is issue of infrastructure and equipment. In some hospitals, they don't even have tonometer. In some hospitals, ophthalmology is relegated, especially in a general hospital. Not like in eye center where everything is about eye, but in other where ophthalmology is a department, you see them battling with the hospital management to buy microscope, to buy CVF machines and all that. So all these ones are some of the limitations. So do we need to join politics and of becoming CMD and other things?
Well, it's a major problem. It's a major problem. Just like you said, some centers don't have even the basic instruments and equipment that you can use to make a diagnosis of glaucoma. But I think, apart from the fact that we are looking for political support and all of that, any window of opportunity that you get, I think we should make the best use of it.
Okay.
Now, say for example, I know of a particular center in a place. Okay, after one patient, I was supposed to be short, had a surgery. The surgery came out successful, maybe not trabeculectomy, not glaucoma surgery this time around. And afterwards, the man has like an habit or a routine of trying to give the department some support. Now, what I said is that you look for opportunities, windows of opportunity. If you see people like that are ready to do one thing or the other, then you can bring up what you think are the essential things that you need, okay? And then present it to them, tell them, defend that particular proposal to such people, okay? So that they can also support what we are doing, because most hospitals, funding is still a major problem for us, and we must find our own way of looking out of the box to meet some of those needs. And then again, we've also looked at our drug companies. In our institution, it's a law now. As a drug company, you are not coming to come and say you are making a presentation, so it's jollof rice and chicken you are giving us. The practice is much more than that now. We have a list of what we need in the department. When you say you are coming for a presentation, we give you the list. You tell us the one you are doing before we give you access. We need to look at how can we make people to be part of what we are doing so that we can get better with it. You know, tonometers can be donated. Okay, we've had donations of tonometer, a non-contact tonometer by a drug company in the past. I don't need to mention their name now. For our institution. Okay, something that was almost like ₦1 million at that time, many years back. Okay, so it's not just like you want to organize a presentation, you want to provide refreshment. It's much more than that. You must have the consciousness of that. How can we make use of every window of opportunity that comes our way, whether through the government, through the non-governmental agencies, private individuals, drug companies, whatever the opportunity is, to make the best use of them, to be able to get what we need to do what we want to do.
Thank you very much. I think we are said so much, but I can see. Okay, can you can say something? I can see Magnus is raising her hand again. Hello?
Okay.
Yeah, thank you. Thank you so much.
All right, ma'am.
Well done for this presentation. I just wanted to chip in about how to get equipment and all that. And I think Dr. Akiemi has touched on some of them. As doctors, we need to really go out and lobby administrators and politicians. And I think we have a lot to benefit from doing that. He has shared with us what they have done. I started the eye clinic in General Hospital in Solo with virtually nothing.
Wow.
And by the grace of God, we're able to reach out with the Osolo of Isolo then. When you are invited to do eye screening by NGOs and all that, I think you should use that opportunity. Akiemi mentioned it. Lash out at every available opportunity. Yes, I'm ready to render my services, but I have a list of items that at the end of this, can you provide it to the clinic? You are not asking them to pay for your services, but you are looking at a situation where you can build up the practice for the use of that community where you are. You find politicians, they want to use you to improve on their political achievements. Yes, we are willing to do that on so and so basis. As long as you're not asking this for yourself, their conscience will be pricked.
I think we lost Dr. Ajayi. Dr. Sadiq,
Because every location always generates funds. But what do? We allow the CMDs to take those funds entirely and decide what and when they will provide services for us. I started off from a general hospital, and I'm sharing my experience because these are the things I had to go through to be able to acquire equipment. And I know at some point we acquired some of our machines. They were Tokumbo that time, second hand, from a company, and we're paying instrumentally. But the machines were installed for us. Today in Nigeria, we have a couple of people that represent companies. So we can also do the same thing. Pick an item based on your cash flow, negotiate with the management. Let's keep a good record of the cash flow coming from the eye services. Can we have 30 to 40% of this and use that to plow back to get the equipment that we need? Then you negotiate with the suppliers. Can we pay you instrumentally? Slowly, progressively, you will find out that you will keep building on your machineries. And that will help us get to where we're going to. When I joined the State House Medical Center, Abuja, so that's the presidency. You should have expected that everything is there. But it took us 5 years to move from basics to acquiring the OCT. No, the laser. They didn't allow us acquire OCT because they felt, was this really necessary? But I collaborated with my next door neighbor, one of the agencies, an ophthalmologist was heading the place, and they put an OCT in their own center. So that way, between the two clinics, we were able to get things done. So we need to reach out. We need to socialize. I'm not saying this because right now I'm in administration. I'm sharing the experience that I used when I was in full clinical practice. If I have to go golf clubbing because I want to achieve something, reach out and do it. If I need to go partying because I need to catch the attention of a politician, reach out and do it. But we are too withdrawn and we think, well, if they don't provide it, they don't provide it. No, the truth is that your skills will rust, particularly when you just come back from training and you are not applying it. So it's important we reach out. Glaucoma management, surgery is the way to go. And we all know that that is it. Again, Dr. Adeyemi spoke to it. You train, you retrain. For those of us who are aging in surgery, we reach out to younger people. Dr. Sadiq is there. I always say to my private patients, sorry, I may have to ship you to Kaduna. And you've done very well. I really appreciate what you're doing. I have a young fellow who is in my, well, she's like 5 years post-fellowship. And I said to her, sorry, you can't get these skills by sitting down. You've got to reach out. And I know she's been doing a bit of work with Dr. Sadiq. And a lot of us need to practice this. I don't know what is happening now with the fellowship training. When we train, before you write part 1, you must have at least done 50 tribecs.
Yeah, that's good.
Same thing with part 2. What do we have today? We find a lot of fellows finishing their fellowship program and not knowing how to do trabeculectomy. And I think Dr. Sadiq just spoke to that. So you guys that are the trainers, you really need to go back again and look at how best to modify this to make sure that ophthalmologists do trabeculectomy. And we also need to take the services to the communities, because in outreaches, by the time you have learned the basic skills, somebody has supervised you, and you go out and begin to do volumes, then you find out that you are not afraid of managing any complication that may show up, because it is the number you do, the experience you acquire at managing most of these complications that makes you confidently offer trabeculectomy to glaucoma patients. But when you are not even too sure of your skills and one or two complications come up and you get put off, you stop surgery, at the end of the day, we are not rendering good services to our citizens. Thank you very much.
Thank you very much, Ma. Actually, I forgot to introduce Dr. Ajani. She's a permanent secretary, federal permanent secretary, Federal Ministry of Transportation in Abuja, Nigeria. So
thank you, Sadiq. But more importantly, I'm an ophthalmologist and I'm in glaucoma specialist. Practice of ophthalmology, but not 100% anymore. So for me, I'm grateful for what you guys are doing at the Young Ophthalmologists Forum, and I actually do follow up on your activities.
Thank you, I appreciate
it. I can't see her online for all the information. Well done.
Thank you very much, Ma. Thanks, Derek. So do you have any other, you see, glaucoma discussions cannot finish. You can keep on discussing and discussing and discussing, and yet you will not reach the end. So at this juncture, I would like to hand over to the YYF officials. I don't know, there was me. Dr.
Yes, sir. Thank you, sir.
Let me just say,
all right.
Before you hand over to them, please just a minute. Dr. Jai mentioned something about the training now and the people that are coming in. Yes. I want to appeal, also join my voice with us, to appeal to our trainers, okay? Because the quality of the products is also dependent on the trainers.
Yes.
We as trainers must be able to impact these people. I remember when we were training, there is no way how you will pass and become a specialist from the center I trained without having been able to do cataract surgeries and trabeculectomy. They were parts and parcel incorporated into the training. So I want to also encourage our trainers, please. Trabeculectomy should be part of the training, incorporated into the training. Just like as we are taking the patient, the trainer, the trainees through the processes of doing a good cataract surgery, the same thing must be done for trabeculectomy. Of course, we can only speak our cases. You know the case that you can use to do that training for them. So that at the end of the day, by the time you are producing the fellow, I was just imagining what you said, that before you went for fellowship, you had not done one trabeculectomy before your training. You understand? And we have a lot more ophthalmologists in Nigeria like that. And that is not what we want. Now, you that you can do it should be able to reproduce other people to do the same before the end of their training. So it's an appeal to our trainers. Please, let's pass this forward. Let's pass it to the next generation. It's mentorship. Yes. One person that is able to do it and move it on to 3-4 persons, and they become confident. By the time they leave the system and go to their own individual places, then they become, something else in all their various locations. I want to thank the Young Ophthalmologists Forum once again for giving me this opportunity to share this experience and lead this discussion today. I believe that we will be able to take glaucoma care in Nigeria to a very, very high level, even in the coming years. Thank you so much.
Yeah, thank you. So I forgot to mention that also in glaucoma department of National Eye Center, we have not yet finished, but we have something like that, maybe a trabeculectomy training for some people. I would like to, first of all, just run the program on our resident and see how, before you open it here to other people. But honestly, we just have to share this.
All right.
Why were you?
Yes, thank you, sir.
Yes.
I would just like to invite the YF chairman in person of Dr. Ugochukwu Eze to round up for us.
All right.
Dr. Eze, you have the floor, please.
Hello. Good afternoon, all.
Afternoon.
Am I audible?
Yeah, we're hearing you.
Hello, good afternoon.
Yeah, afternoon, Dr. Eze, we can hear you.
Okay. Okay, I've been asked to give the vote of thanks. So, good afternoon, all participants, all our senior colleagues, and invited guests that were invited to participate with us and join us as we mark our last activity of this year's World Glaucoma Week. We are glad to have you all. I wish you this opportunity to also thank our speakers, especially Dr. Akinyemi, who gave us an elaborate talk and summary of glaucoma services in Nigeria, and also our moderator, Dr. Sadiq. We appreciate you greatly. Just know that when you do this kind of thing for us, we'll be tempted to come back later when next we need something like this. Just to say we appreciate you. And to our senior colleagues that contributed, and for all the elaborate discussions we had, we've taken a number of notes, and I believe YOF will join hands with Glaucoma Society of Nigeria, and we'll try and make some of these things achievable, those that are within our reach. And we'll keep on making our little efforts in our small spaces to improve the lot of our patients and improve our practice. Thank you, everybody.
Thank you. We can have